slot was for Dr. Safdar Ali Malik. Unfortunately, he is not able to join us right now. So moving to the next speaker, Dr. Samina Anwar. She is one of our very experienced gynecologists. She is a graduate of Allama Iqbal Medical College, Lahore. She holds fellowship of College of Physicians and Surgeons of Pakistan and OBS and Gynae. Dr. Samina Anwar became a member of Royal College of Obstetricians and Gynecologists and also hold accreditation in colposcopy, Birmingham, UK. She was awarded fellowship by RCOG in 2011. She worked as senior consultant of Gynae in Northwest Armed Forces in Saudi Arabia for 5 years. She also worked as associate professor in King Hamad University Hospital and was responsible for training of undergraduate and postgraduates. She conducted lot of research projects like role of methotrexate for management of cervical ectopic, prophylactic role of misoprostol in prevention of BPH, and prophylactic role of magnesium sulfate in prevention of maternal and fetal morbidity. She is author of 4 papers in Bahrain Medical Bulletin. She presented paper in RCOG World Congress of OBS and Gynae in 2012, 2013 and 2015 in Birmingham, Manchester and Brisbane, Australia respectively. She is author of many papers in JSOBG. She is currently working as consultant gynecologist at Jutai Medical Center, Lahore and Hamid Latif Medical Center. We are highly obliged to have her as fertility specialist in our consultant panel. Today her topic of presentation is ovulatory disorders and this session is brought to you by Geneva Healthcare. So I request Dr. Samina Anwar to please come on stage. Thank you.
Ladies and gentlemen, my name is Dr. Samina Anwar and I welcome you to FertiVision 2024. I hope you are enjoying and I would like to thank the sponsor and who have arranged this nice, full of knowledge conference, and I hope you will go home with maximum knowledge regarding subfertility and benefit the patients who visit you. My topic is ovulatory dysfunction. If we go to the definition, ovarian dysfunction is abnormal or irregular or absent ovulation. Diagnosis is by the infrequent menstrual cycles or sometimes there is amenorrhea. And you can get from history, examination and hormone test. Ovulatory disorders are common in girls and women of reproductive age and are associated with episodic or chronic dysfunction of hypothalamic pituitary ovarian axis. What are the causes of ovulatory dysfunction? Number 1 is the polycystic ovaries. Number 2 is hyperprolactinemia. It could be hypothyroidism, hypothalamic pituitary dysfunction, diabetes, premature ovarian insufficiency, obesity, which could be excess weight gain, loss, excess of exercise. Diet, lifestyle, stress, infections, chemotherapy, radiotherapy, toxins, they all affect the ovulatory function. The drugs which are used, oral contraceptive pill, estrogen, progesterone, antidepressants, antihypertensive and antiemetic can also interfere with the ovulatory function. Polycystic ovaries is the number 1 cause, and if you see from this diagram, the woman can have if you see from there, starting from head to toe, there could be thinning of the hair, temporal part length, then there could be acne, hirsutism, problems about fertility, menstrual problems, low sex drive, irregular periods, and it could be increase in the testosterone level, increase in the insulin, metabolic syndrome in the form of high cholesterol, insulin resistance, diabetes, and of course excess weight gain, which can affect the image of the woman and again leading to depression. If you see this picture, it's a typical picture of pearl necklace appearance. The follicles are luteinized and they are present at the periphery. Polycystic ovaries, the incidence is 8 to 13% in reproductive age and about 70% are undiagnosed. Diagnosis is based on menstrual history, serum progesterone, FSH-LH ratio, and pelvic ultrasound. When we do clinicals, there is elevated LH level, GnRH levels may be increased, and FSH level are muted or unchanged. As a result of increase in the GnRH, stimulation of theca cells, and there is increase in the androgens. Follicular arrest is there, but it can be managed by exogenous FSH medications. Excess of endothelin in the fat cells convert to estrone and affecting the brain, which is responsible for controlling the hormones, metabolism, and ovarian function. What is the treatment? Treatment is weight reduction. It's very important in the clinic to see the BMI. We do the BMI, that is the normal is between 18 to 24, and that is your weight in kg over height per meter square. So every woman should be advised who are coming to the fertility center that their BMI should be between 18 and 24. So if we come to the medication, it's very important in these PCOS patients to regulate their menstrual cycle. And I usually prefer to give them Femila for 3 months, and then we embark on either induction of ovulation or if we are doing other ART techniques. Metformin to decrease the insulin resistance and improve the hyperglycemia and to work against increased glucagon. Probiotics are given, Genistol is given, which improves the quality of the eggs and increase the ovulation rate. Surgery is the method of the fast. When we were being trained, the vaginal section of ovary was done. That was in cases of Steen-Lewinson syndrome. Later on, they have started doing laparoscopic ovulation diathermy. But now, with the time, we have come to the conclusion that respect to the ovary and decreasing cancer to the ovary will be much beneficial. And of course, IVF and ICSI can help if there is a prolonged history of infertility. Hypothyroidism can be another cause. The incidence is 2 to 4%, and it causes heavy period anemia, amenorrhea, underactive thyroid, and the fat will be deposited in the body. Meta-analysis has showed that obesity was associated with increased 1.8-fold of developing hypothyroidism. After treatment, 80% of the women can conceive in 6 weeks to 1 year. According to the research, thyroid antibodies has an association with the reduced pregnancy rates. The use of prednisolone can help in this matter for the patient's IVF success. So, when you do TSL, TB4, we also do the thyroid antibodies to diagnose that whether the antibodies are responsible for hypothyroidism. So this is, you can see the diagram from top to bottom how this woman is affected. And the women usually come to our clinic in the being treated by induction ovulation, but they don't have their TSH levels done. So see, they will be hair loss, feeling cold, they could be swelling in the neck, fatigue, slow heart rate, weight gain, menstrual changes, it could be dry skin, and sore arthritis, etc. will be present. Next, it could be hypothalamic amenorrhea, hypothalamic dysfunction. It is a malfunctioning of hypothalamus, which is responsible to control the brain in parts like pituitary gland and regulates various functions in the body. Common symptoms of hypothalamic dysfunction are irregular or absent periods. Causes could be surgery, tumors, radiation, brain injury, and genetic condition. Recent and severe weight loss, excess physical exercise, emotional stress, nutritional deficiencies, and high or very low weight can be the cause of hypothalamic dysfunction. The later cause can be addressed by the lifestyle changes, weight loss, and stress reduction techniques. Most of the cases of hypothalamic dysfunction are treatable by simple lifestyle, hormonal replacement, and few cases might need surgery. Then we come to another cause which is very common in our outpatient in fertility clinic is the hyperprolactinemia. This is one of the hormones that is produced by the posterior pituitary, and it can disrupt the ovulation by increasing it can reduce the estrogen production and causing infertility. It is raised in pregnancy in cases of prolactinoma if the patient is taking antidepressant, antihypertensive, antiemetic, or on opiates. Symptoms are again irregular menstruation or low menstruation, vaginal dryness, or bacteria. You have to do a simple blood test of prolactin, serum prolactin level, and see what is the level. And if it is very excessively raised, then it needs doing MRI to exclude the tumor. Medication used in our clinic are bromocriptine and carboplatin. Treatment options for tumor are medication. Most of the tumors even get reduced by the medical before you embark on any invasive procedures. This is the figure which is showing the prolactin level is reduced, the cisplatin is reduced, and it's signaling the hypothalamus to reduce the GnRH hormone, and again it is signaling that the pituitary to decrease LH, FSH, and there is loss of ovarian function. Next cause is very common, again it's diabetes. Type 1 diabetes appear to be one of the causes of ovarian dysfunction, and again it can present as delayed periods, menstrual irregularities, and possibly early menopause. However, more ovulatory cycles are observed in girls with type 1 who have optimal control as compared to insufficient control. So, studies of women with type 2 diabetes are inconsistent but suggest increased anovulation and early menopause. Differences in reproductive aging between women with type 1 and type 2 diabetes raise the questions about potential difference in the mechanism leading to ovarian aging. The literature suggests that insulin aids at the diagnosis and weight played an important role in ovarian dysfunction. Obesity is again one of the cause of ovulatory disorder, and it is because of the interference with neuroendocrine ovarian function which reduce the ovulation rate. Fat cells grow and release estrogen. Increased estrogen level can cause your body to react as it is on the contraceptive pill. Both oocyte metabolism and maturation are impaired. It also raises the insulin level, the fatty acid, adipokines, affecting the competence of the oocytes. It affects the endometrium and the risk of miscarriage is increased in obese women. By losing weight, blood sugar level, insulin resistance, and balance of hormone is restored and fertility is improved. Then we come to another common, not very common, but we see some cases with premature ovarian failure. Now the term is being used as premature ovarian insufficiency. It affects 1% of the women, and the women who stop working before the age of 40 years. They may start getting irregular periods before they go transition to menopause. It has a psychological sequence and major health implications. The causes of premature ovarian insufficiency can be genetics, autoimmune, radiotherapy, chemotherapy, infections, viral, bacterial, toxins like cigarette smoking, unexplained, and a lot of medications by Hafeez. Prevalence is 10 to 28% in primary amenorrhea, whereas in secondary amenorrhea it is 4 to 18%. Early studies suggested that FSH level of more than 40 is associated with permanent cessation of ovarian function due to ovarian follicle depletion. Intermittent ovarian function and even spontaneous pregnancy have been reported in younger women with spontaneous premature ovarian failure subsequent to diagnosis. Premature ovarian dysfunction or ovarian insufficiency may be more appropriate term rather to use the term like failure. What are the symptoms? Symptoms are hot flashes, night sweats, infertility, brain fog, and mood instability. How you will diagnose it? By doing serum, FSH level, AMH, estrogens, and seeing antral follicles on transvaginal scan. HRT is the treatment of choice for the patient with premature ovarian insufficiency. It gives the body estrogen and other hormones which the ovaries are not making. HRT improves the sexual health, decreases the cardiovascular diseases, stroke, and osteoporosis. The upcoming therapies, the stem cell therapy, is expected to restore the ovarian function and fertility for premature ovarian insufficiency. Stem cells are early, undifferentiated cells with ability of self-renewal, unlimited proliferation, and multi-differentiation. Now we see these cases very often in our clinics, diminished ovarian reserves. These are the poor women who have been treated for 5 to 10 years by induction of ovulation. By the time they come to know there is an IVF center and I can go for help. Decreased ovarian reserve is decrease in the quality and the quantity of oocytes leading to impaired fertility. Ovarian reserve decreases after the age of 30 and decreases rapidly after the age of 40. Ovarian lesion or prior ovarian surgery also decreases the ovarian reserve. Age and decreased ovarian reserve are independent predictors of infertility and thus poor response of the treatment. Decreased ovarian reserve does not mean that the woman cannot become pregnant or pregnancy is not possible. So how you are going to diagnose it? You are going to do the FSH level, estradiol, AMH and antral follicle screening. This you can see a diagram in which there are very reduced amount of follicles. See 1, 2, 3, 4, 5, 6. So most of the women who come in the later part of the age have all the treatment of induction ovulation for years. They usually end up with this kind of finding on our ultrasound scan. So screening should be done if a woman is quickly or urgent, if age is more than 35, had ovarian surgery or ovarian lesion, and they have responded poorly to ovarian stimulation with external gonadotropins. If FSH level is more than 10 milli international units per ml or estradiol is less than 80 pg per ml. AMH is less than 0.1, it predicts lower chance of pregnancy. Antral follicles, if the antral follicles is low, 3 to 10, pregnancy chances also get compromised. So what is the treatment? Treatment is dihydroxyandrosterone. This is one of the medication which improves the blood supply and increase the number of antral follicles. And CoQ10 is antioxidant which improves the quality of oocyte. So if the quality of oocyte is good, the chances of pregnancy is higher. You can offer them ovulation induction or IVF. It can be successful in a younger woman which has no other risk, and in the older woman you have to do the screening to put the healthy embryo to reduce the chance of miscarriage and trisomy abnormality. Then you can do the PRP, which is again an upcoming modality for the treatment of reduced follicles. Donor oocytes can be offered, but we don't do it in our center, and it is practiced abroad. Now we come to a very common problem in the clinics is the endometriosis. Women affected by endometriosis, incidence is 10 to 15% in the reproductive age group. It is multifactorial, but ovarian dysfunction is one of the cause of infertility. Altered follicular development from peri-ovulatory resulting in decreased ovarian reserve and low quality of oocyte. The inflammation, it destroys the functional structure of ovarian cortex that protects the dormancy of primordial follicle. Premature eclampsia occurs and early activation, which is regarded as burnout. Aberrant immune reaction present in mature oocyte, affecting the oocyte competence and growth of endometriosis. So you can see this is the laparoscopic view, and you can see that the bowels are attached. Bowel is attached to the uterus, and there is increase in vascularity of the surrounding organs, and the ovary on the left side is also showing the adhesions. So it is the trauma or destruction of the cortex when the woman is affected by the endometriosis. This again is a typical laparoscopic finding when you see the matchstick burns and increased vascularity. This is the laparoscopy is the gold standard for diagnosing the endometriosis. Usually what happens that the retrograde menstruation occurs and the endometrium get implanted over the ovaries, macrophages, they get activated, there is fibrosis which affect the cortical tissue that contain the dominant follicle and release growth factors, cytokines, which is responsible for metaplasia and angiogenesis, and they lead to the invagination of endometrium into the ovaries. Ovarian steroid production, estrogen, progesterone are reduced and luteal phase get affected. Oocyte competence is decreased and oxidative stress is increased by the chocolate material. As I have told you that ovarian reserve in endometriosis, primordial follicles are formed in the fetal life and they remain dormant till they come to the they are activated in the later life. Any trigger which stimulates the primordial follicle is going to infection, they are going to decrease the AMH level, which will result in the activation of follicle nest, since AMH is an inhibitor of primordial follicles activation. Procedure resulting in sudden decline of AMH are surgery, chronic infection, leading to enhanced follicle recruitment and follicular atresia. So we lose the follicles in this way in endometriosis. But saying all that, there is still light at the end of the tunnel. Systematic and meta-analysis have shown that the impact of ovarian endometrioma on IVF and AC. In my clinic, I have come across many patients with endometriosis, and they have like endometrioma 4 centimeter, 5 centimeter, and they have multiple ovulation inductions. So if they are symptoms free, we don't need to do or proceed to the surgery. If we are capable of seeing the follicles, we keep the conservative management. But what happens that in some patients, the number of repeat oocytes are reduced and increased in the cancelling of the cycles. In women with operation, it decreased the ovarian reserve, increased the FSH level, and clinical or the live birth weight was not significantly affected. This shows that the endometriosis affects ovarian reserve but not the final outcome of ART, which might be overcome by controlled ovarian stimulation. So the treatment is chronic inflammatory condition should be avoided and treated actively. Frequent recurrence after surgery, repeated surgery should be avoided. Early treatment with combined oral contraceptive will progestogens to alleviate the symptoms, and long suppression of ovulation and consequent menstruation beneficial to reduce the growth of lesion and protect ovarian function and restore the endometrial receptivity. Modification of surgical treatment is very important for ovarian endometriomas, and better to go and do laparoscopic. What is the modification? If you do 5 centimeters endometrioma is present and patient has a good AMH, and it is symptomatic, you can drain the endometrioma, remove the capsule, but do minimal cauterization. And if you have this fear that you will end in a lot of bleeding and all that, better to just drain and do minimum and come out. The other magical drug is Zoladex injections. If you give Zoladex for 3 months, monthly injection, it can control the disease, decrease the symptom, and CA125 level also come down. Now we come to one of the another scenarios which we see in our practical experience is empty follicular syndrome. It is a complete failure to retrieve oocyte despite normal development of follicle. It is sporadic and true syndrome implying acceptable results in subsequent cycle. What are the predisposing factors? It could be older age, decreased ovarian reserve, ovarian resistance to stimulation and obesity, and increased insulin resistance. The woman can be genetically predisposed to the development of follicle without egg. There could be intrafollicular fine defects not allowing the egg to detach from the follicle. GnRH agonists used to trigger in antagonist cycle to prevent ovarian hyperstimulation. We don't use agonists to trigger. We usually use HCG. Few data are available that the incidence of empty follicular syndrome in case of trigger strategies alternative to HCG bolus. So one should have a cutoff value you should do before embarking on ovulation retrieval, do LH and HCG levels to see that the levels are okay to go ahead and avoid empty follicular syndrome. During follicular development, the oocyte cumulus cells, they form bands, and the milk cycle search by bands and bridges, which have to be broken to let the oocyte release in the follicular fluid to be aspirated. This function is done by the mid-cycle search by HCG or GnRH antagonists. They promote the rupture of the junction and allow the oocyte to freely float in the fluid, and then it can be aspirated. Genuine, empty follicular syndrome can be genuine or false. Genuine empty follicular syndrome, failure to retrieve when the beta HCG level was about 5 milli-international units per ml. And they observed 2 cases out of 18,000 women. Prevalence was 0.01% and false prevalence was 0.07%. Mason et al. He seen in 2011 that administration is carried out when at least which usually our practice is to give HCG trigger when the follicle size is 17 to 19 millimeters. This is the appropriate time and with appropriate estradiol levels. A recurrent form of empty follicular syndrome suggests existence of patient predisposition. It could be perisymmetric inversion of chromosome 2, which is responsible for recurrent genuine empty follicular syndrome. This chromosome includes coding of inhibin, responsible for premature ovarian aging and reduction of ovarian cycle. Another factor can be the predisposition of LH-HCG receptor. It could be less receptive to HCG, and it doesn't allow the bridge to break. But by giving a repeated HCG, this can be broken and the oocyte can be released. False empty follicular syndrome is defined that failure to retrieve oocyte in the presence of low HCG or circulating LH when after ovulation trigger. It could be error in the timing of giving HCG, lack of expertise in maintaining the drug's temperature, excess light. Administration of HCG is usually after 34 hours till 38 hours, and the peak is at 36 hours. The effect of HCG is impaired if oocyte retrieval is carried out before 34 hours or after 38 hours. It could be incomplete aspiration, as I was telling you in this workshop hands-on transvaginal, that if incomplete aspiration is done, if the follicle is not totally collapsed, you might be leaving the oocyte in, or too low aspiration pressure, air leakage, or any other defect in the egg collecting system. At the time of oocyte retrieval, two simple things can be done to diagnose and treat empty follicular syndrome. First, carry out a blood test before starting the oocyte retrieval, and HCG administration time and technique, and puncture follicle one by one. The embryologist is available next door, and when you puncture the follicle, you give that test tube to the lab, and they read for us whether the oocyte is there or not, rather than starting and puncturing all the follicles. So if they are not achieving or they are not seeing any oocyte, the other thing can be done is rescue HCG administration. Is to plan another HCG dose and schedule a second oocyte retrieval in 24 hours. And they have seen Papier et al. That by giving a second HCG and retrieving in 24 hours, the second oocyte retrieval yielded 12 oocytes. 3 embryos were transferred but no pregnancy. But the patient got pregnant after frozen embryo transfer after 2 months. Similarly, Ved et al. He obtained twin pregnancy after rescue HCG and pregnancy achieved with frozen embryo transfer, as endometrial receptivity during subsequent cycles are better. It can be met with repeat IVF with the same or different protocol. The number of patients who had repeat IVF in that study was 37, and mature oocytes were obtained in subsequent cycles with 7 live births, support the idea that repeated stimulation may be helpful in retrieving the oocyte. The other modality of treatment is rescue IUI. Rescue intrauterine insemination in a woman failing to retrieve oocyte at ovum pickup. Assisted Reproduction Genetics June 2024 journal has published this study. In these cases, IUI can be a prompt option, but possibility is poorly studied. Rescue IUI was performed in 96 patients out of 3,500 oocyte retrievals. 6 live births were attained, corresponding to 6.2%. But there are certain prerequisites for that the semen analysis should be normal, at least 3 follicles should be there, and tube should be patent. This procedure, though efficacy is low, but is simple without a risk. A new modality that is coming is PRP. So this is the platelets. They are processed and they are injected where it's either in the ovaries or in the endometrium. And if the blood is drawn from the patient, it is about 15 to 50 milliliters are required. It is centrifuged, processed and injected into the desired site. In IVF, PRP can be injected into the uterus. It improves the endometrial thickness, and in the ovaries, the success rate for the pregnancy is 70 to 80% in improved egg quality and quantity. Success rate of IVF after PRP, because it improves the ET, the pregnancy rate improves 44% and implantation rate improves 27%. Start working in 2 weeks and you can do IVF in 2 months' time. The last but not the least modality is frozen eggs. The woman who has not yet planned but is suffering from certain problems or had to go for chemotherapy, radiotherapy, we can retrieve the eggs and we can freeze them. The survival rate is 61%, and if you go by freezing technique, it is 90 to 95%. And 70% pregnancy rate can be achieved. Fertilization is 70% and pregnancy rate is 45%. And if the egg age is less than 35, then the success is 50%, and if 15 oocytes are retrieved, then it could be 75%. So take home message is education and awareness for women, diet and supplement to improve the immune system, early diagnosis and treatment of chronic inflammatory condition, exercise to improve the blood flow and avoid stress, referral in appropriate time for IVF center, educate to avoid medication from non-medical professionals, and respect the evidence. So famous saying is, a stitch in time saves time. Thank you. Any questions?